Actually, I wanted to ask you, going back to the MitoQ, what time frame would, if you were going to get an improvement on it, what, you know, for it to give time to work in the body, what would you expect to be some?
I mean, from my, you know, own taking it, like 2 weeks to a month, I think is the, I mean, 2 weeks I would say, you know, so you've got to.
If you took it for 2 months and you didn't feel.
And you didn't feel anything, then sure.
It's not that pathway or whatever. It's not,
well, you know,
that's not the answer.
it's a subjective thing, and if I'd taken it for 2 months and I didn't really feel that there was any benefit, then I would have stopped taking it. What I did was that it says take 2 and take in the morning, because actually if you do take it at night, you feel a bit wired, so it's doing something.
Yeah.
So I took it in the morning. I started by taking 1, not what it said on the bottle. And I did that for a couple of weeks. I got no effect, and so then I went up to 2. And for me, taking 2, I thought had an effect. You know, so this is all very subjective. You know, just like you, I'm deciding whether it's worthwhile. Yeah.
Do you think you should take it in conjunction with some other supplements, some vitamins and minerals?
I don't think there's any counterindications, and again, I mean, I'm happy if Ros wants to come in on that. I mean, I take now, because I'm over 70, I take multivitamins as well, you know. I go out exercising 3 or 4 times a week and try and do about 4 hours of walking and things like that, you know. So you kind of feel if you're going to be doing that, you know, you want to be in the best. And you know, some of these things as you age, you know, are affected. So I don't know if that's necessary or not, you know. I used to not take anything, but as I've got older and older, I kind of, I've become a bit more scared, I guess, that I'm not in maximum physical.
They haven't shown anything that works in by, you know, to enhance that, potentiate the effect of the MitoQ.
Yeah, I mean, MitoQ, I should say, MitoQ have come out with some new products, MitoQ Heart and MitoQ Liver and whatever, and I looked up just this last week, you know, what's the difference between those? And actually it's because they add 1 or 2 other things in there which are well known, which, you know, supposedly good for heart health. My own conclusion would that there's no necessity for us to be paying an extra $10 a month for these things. So at the moment I would say if you're going to take anything, just go with the straight MitoQ. That's what I'm going to be doing anyway.
Can I just ask, on the section there where you said where you want to go next and these things you want to
study? Yep.
Have you got an idea of time frames on those?
Well, like for this, what we'll do is we'll ask for permission, you know, for our existing group to come and give will they come and give another blood sample? And we've got to, when the machine comes, we've got to make sure that we can use it properly. So that I should take a couple of months. I'm wanting to make sure we complete these studies in 2018. That's my goal. Okay? And I'll talk a little bit more about the new things. The epigenetic code work, we've got that well underway, and I would hope that within 6 months we will have data on that. I mean, in a way, I've got a limited lifetime at the university, so I'm on urgency mode at the moment, so I'm not just, you know, we're doing it as quickly as we can. The relapse stuff, you know, again, we hope that certainly I've got a plan for that by the middle of 2019. So we do worry about those kinds of things, you know.
You're talking about the impact of chronic fatigue on the brain. There's a lot of publicity out there at the moment about people pushing brain food, how that has an impact on balancing all these bacteria and all the stuff in the gut, which is exactly what you're talking about, and how that has, if you get that wrong with your food, you can get it wrong with your brain and vice versa. Just wondering if that can fit into your research, or their research can fit with your research, or whether it's about.
Well, all I would say to that is that there's no real proof that eating certain foods has specific benefits in this illness, and the aim with diet should be to get really good nutrition lots of variety and not therefore needing too many supplements, and only going for supplements where there's good research proof, such as perhaps with the MitoQ, to benefit people for the particular illness that we're talking about. But I don't think there's any proof that specific diets are going to be helpful. Would you like to
No, I
comment?
think they're basically saying the same thing.
Yeah. One interesting thing is I work on Alzheimer's disease as well, and if you look at the risk factors for Alzheimer's disease, it's the same as for cardiovascular disease and diabetes. It's, lack of exercise, it's poor nutrition, smoking, the same sort of thing. So I think there's, holistically, as Roz said, just having good nutrition and taking care of yourself is probably the best thing you can do, really.
Can I just ask, when you were talking about in Norway, when we talked about and the other thing, it was kind of like something we stumbled across, wasn't it? Because we were talking about chemotherapy. I'm reading about a similar sort of thing with low dose naltrexone back in the 80s, studying for drug overdose and alcoholism. That in treating those, the chap whose name I've forgotten seems to be, he discovered that people with chronic fatigue responded very well. So has there been any work done on that, or scheduled anything you've heard of to do with low dose naltrexone?
Well, I've had a number of patients who've wanted to try low-dose naltrexone, and I think the research into it is still fairly slim. And, if I just took a kind of ballpark figure of who responds, about 1/3 of the people who've tried low-dose naltrexone have improved a little bit. About 1/3 will say they haven't changed at all, and about 1/3 will have had side effects that have created them stopping it. And I think that happens with a lot of the things that are, somebody's just pulled out of a hat to try with this illness. You get that 3-part breakdown. I don't know if you've got any.
My PhD student has been on this. He was highly excited about it initially. And now he's stopped it. But one of the difficulties, I think, is to know, as an individual patient, what's the appropriate dose too, So a dose can be recommended, but it might not be, even though it's low, what is low and what's appropriate for each patient. So I think each person has to kind of, if they want to persist with it, have to just try adjusting the doses to see if they can get a sweet spot. Would that be fair enough?
And even the time of day, because some patients with it get insomnia and some feel terribly sleepy on it. So, there's a lot of hit and miss over it, and I don't think we've got any proper trials that have been done that give us the requisite guidelines as yet. It's a bit of a hit and miss thing.
Could it be one of those things like the thing when we talk about subgroups? And could it be one of those things where, a bit like maybe we listen to rituximab and other things, that for some people these things work and for others it doesn't, and maybe it's worth a go?
Well, I think we have to say that as humans we're also very, very different, and the way illness affects us is very, very different. It doesn't matter what illness you take, there will probably be always subgroups that will respond to one form of medication better than another, and that would apply to heart disease and thyroid conditions and so on. So I think this illness is no different in that way, and we haven't got firm enough guidelines, and that's where something like this rituximab trial is much more strictly controlled and will possibly give us better guidelines as to whether for some patients it's going to be useful and doses and what have you.
Yeah, I mean, in the rituximab trial, those that were more severely affected with ME didn't seem to respond, I think, certainly as well. So, other subclass, I'm not against the idea of subclasses, but, we all have genetic susceptibility differences, My wife has the illness and she nursed my daughter intensively, I was sort of in the same household. I didn't sit up with my daughter every night because my daughter wanted her mother, but, why didn't I get it, and why did my wife apparently, you know, and was that genetic susceptibility? I just don't quite understand. And the other thing which the Norwegians did show in their energy studies is that males and females respond differently in their energy pathways, so they can show a male-female difference, you know. So there's quite a lot of subtlety.
Yeah, and I think that ties in too with the pregnancy issue that Warren brought up at the beginning, that certainly there are very real differences in men and women who have this illness, and pregnancy does seem to be a positive outcome for many women who have this illness, and similarly older women who are put on hormone replacement, estrogen, with this illness will often do very, very well. Not all will, but some will. And improves their health enormously. And fortunately, we've got much more reassurance coming through now from people like the World Health Organization that hormone replacement therapy is actually a lot safer than we had been led to believe, that the risk factors are not as dire.
It was interesting to me in London because I mentioned, you know, my daughter's pregnancy, and because I talked to Ros about this, and I knew there was quite a lot of anecdotal evidence, but people there didn't seem to be so aware of it. And so I was asked by a question, are you going to recruit a group of young women and ensure that they get pregnant so you can actually do the study? And I ducked that question, but there were a lot of mother-daughters came up to me afterwards. I've never seen so many mothers wanting their young daughters to get pregnant, you know, as a result of the discussion. So it is interesting that, you know, this isn't sort of more broadly known that it can be helpful, but I guess some women don't respond, do they?
Yeah, I mean, I think again, I've had women who've become pregnant who will have got worse. And perhaps it depends on lots of other things too, you know, how old they are, how sick they were at the time when they got pregnant, and so on. But the majority do improve during the pregnancy.
But isn't with a lot of autoimmune diseases that women can improve during pregnancy, but afterwards it can be quite a crash?
Yeah, I think Dan at the front here mentioned that a number of autoimmune conditions are improved in pregnancy, things like lupus and Sjögren's syndrome and various ones.
You mentioned that there may be an unknown component of the blood, in the blood of ME sufferers, that can be passed to healthy blood cells.
Yeah.
What implications does that have for blood transfusions, and can it focus minds and attract additional funding to discover biomarkers?
Well, that's quite a profound question. I mean, obviously, you know, this is only a kind of almost an anecdotal finding that Davis has kind of communicated, and they're just starting to do this now, and it certainly would in terms of, you know, wanting to be very careful in terms of blood transfusions. Yeah, I mean, anything which could come out which kind of makes people realise this is a really important issue, and so therefore you have to put funding, you know, into it, would be extremely helpful. I mean, the big thing in the United States was the Institute of Medicine report that came out in 2015, which really criticised the health profession there for not taking this disease more seriously and not serving their patients well. And, you know, we've seen a big stirring up, haven't we, with the NIH and whatever, of wanting to lean over backwards to try and support ME/CFS research as a result, I think.
But if you could show a link that could contaminate the rest of the population,
yeah, I know.
Suddenly they're going to go, whoa, this is serious, and pour money into it.
In New Zealand, people with ME aren't allowed to donate blood to the
No.
I didn't know.
Yeah.
That we have people like myself that never have not.
I think, yeah.
There was some study that came out where they, do you remember this was, where they injected people, blood from any people into, was it rabbits or some animals, and they died.
That was in 1955.
Probably in the 1980s, that's when it got.
There's a paper from 1955, it's an Australian paper where they did that.
Was that?
All sorts of body fluids and fecal matter and all sorts of things, and injected them into monkeys, and some of the monkeys died. So,
Okay, thank you.
going back to what you're talking about, like mind and cue, is specifically targeted, and the potential for metabolic sort of a lack of processing and breaking down the things that our body needs into the correct form. I know that's not the technical way of saying it.
Said it very well.
We know, and like Rose, we've sort of had B12 injections and things like that. So another thing that's come up is like B6 and B9 in the activated forms or reduced forms, rather than, again, because some bodies can't transfer that into an active form. So to take those active supplements of B6, 9 and 12. Have you any experience with that helping in energy building or being beneficial?
Not with B6, not with B9 or B6 specifically. I use vitamin B6 pyridoxine to treat premenstrual disorders, which is, again, a little bit different, though people with CFS get a lot of premenstrual problems. And some of the earlier studies have shown that vitamin B12 is low in the cerebrospinal fluid in patients with this illness, so that gives us some justification to use it. And I know Mary Ann Fletcher's team in Florida have done quite a lot of work looking at B12, but I don't know anything about B9 and its benefits actually.
I mean, you could argue that if the metabolic pathways are low, something like pyridoxal phosphate, the B6, which is an essential cofactor, if that's a limiting sort of effect, you might be able to get some stimulation of the metabolism by doing it, but it would have to be kind of limiting. That would be the case. So, I mean,
it's just the thought, a bit like the MitoQ. It's like, obviously it's not an answer to the problems, but something that might support or help.
Yeah.
Symptoms whilst we're waiting for some answers.
Again, I'm not, don't take what I'm saying about MitoQ that I'm advertising it, but the kind of the thing that attracts me is that the energy powerhouse of the cell is a critical sort of central thing. Each cell has to have energy supplies, and then the muscles and whatever, the brain and everything. So that's a kind of a central control point. If that's not working right, you can sort of understand how holistically we wouldn't be doing very well. So if you can tweak that, maybe, that will be kind of important rather than focusing on this cytokine or this over here or that over there. It's more of a kind of a groupy thing, as it were, a more holistic kind of thing. But,
might be one subgroup that responds very well to that.
Yes, I mean, the trouble is, as I think Ros has said, is that, and vitamin B12 is the same. I mean, my daughter had vitamin B12 and had kind of was worse as a result of having that. So no patient responds exactly the same, it appears, to these kinds of things. So, but then it's the same, isn't this the same in most drugs that are used? There's a certain percentage that do well and some that don't, and that's where the concept of personalised medicine, if we understood everything, comes in, isn't it?
Yeah, if you took the routine drugs that you use to treat high blood pressure, I mean, many people have side effects on certain ones but do well on another, and a different group of people will do well on another, and so on. So I think, as you say, in medicine, it's a very complex science which we can't even begin to understand fully.
You talked about the higher instance of anaerobic markers post-exertion.
Yeah.
Is that indicative of when you feel a big slump and you feel run over by a bulldozer just suddenly? Is that the switch from aerobic to anaerobic?
No, not necessarily, because anaerobic metabolism can sustain you. I mean, when you start getting lactate build up, then it can, and if you imagine doing 100 metres sprint, at the end of the sprint, you would feel pretty tired because you're actually working to capacity, but I don't think it's just the switch. That's that's a semi-scientific response, I might say. It's more
Again, everyone's different.
Yeah. And in many ways, some of my comments, including about MitoQ, is not so much it is a bit scientific there, but it's that if we start from the patient, you know, I'm very in tune with the suffering that patients have, having gone through it, you know, with my daughter and my wife's illness now, and the sense that what we need to do is to try and find something which is really at the patient level. Individual patient might help that individual patient, you know, and it might not be the same thing for you and the next person, but if you can find what helps you, to me that's fantastic, you know, and so on.